about hematuria in children. I am not going to specific details of any specific disease. Just we are going to approach how to approach the hematuria in children. Hematuria is defined as by the presence of an increased number of red blood cells in the urine. It can be macroscopic, which you can see with the gross eye, or which is apparent only on urine analysis. It is defined as the presence of at least 5 red blood cells per high power field of centrifuged urine and or 5 red blood cells per microliter in uncentrifuged specimen. So microscopic hematuria is defined as more than 5 red blood cells per microliter can only be detected by urine analysis as urine color remains normal. And persistent microscopic hematuria is defined as it is more than 3 positive separate samples that occur more than 1 week apart without any prior exercise nor during the menstruation in girls. Isolated asymptomatic microscopic hematuria is the presence of microscopic hematuria without any clinical symptoms or any other abnormalities in the urine analysis like proteinuria. Macroscopic hematuria is when blood is visible in the urine without microscopy and is more likely to come from the bladder or urethra rather than the kidney. What is the pathophysiology? It is mainly because of the structural disruption in the integrity of the glomerular basement membrane caused by the inflammatory or immunological process, which causes the leakage of the red blood cells into the urine, or toxic disruptions of the renal tubule, like acute tubular necrosis, or mechanical erosion of the mucosal surface of the genitourinary tract. What is the incidence and prevalence? Macroscopic hematuria has been estimated incidence of 1.3 per thousand. The incidence of microscopic hematuria in school children was 0.32 in girls and 0.14 in boys when 5 consecutive urine specimens were analyzed over 5 years. Actually, this is a old study in 1980. After that, there are no specific studies to see the incidence in children. And overall, hematuria is present in 5 to 6% of general population and 4% of school children. Hematuria mainly predominates in girls versus boys. And out of these, only less than 10% of hematuria is caused by the glomerular bleeding. Most of them are because of the non-glomerular bleeding or other systemic diseases. The American Academy of Pediatrics does not recommend a screening urine analysis since 2007. Before 2007, AAP recommends normally one urine examination at 4 to 5 years before entering into the school as a health checkup. And at 11 to 21 years before going to the higher school, they are usually recommends one urine analysis. But from 2007, they are not recommending any routine urine analysis before school exam joining. These are the various causes of hematuria. They can be divided into glomerular or non-glomerular. In glomerular causes, you have acute post-acute glomerular nephritis or IgA nephropathy or benign familial hematuria, systemic infections, membranoproliferative glomerular nephritis, and hemolytic uremic syndrome or Henoch-Schönlein purpura and Alport syndrome. Few of them, they can cause recurrent hematuria, and few have familial association like benign familial hematuria or nephrolithosis or hypercalciuria. And these are the common causes of hematuria in newborns, like renal vein thrombosis, renal artery thrombosis, autosomal recessive polycystic kidney disease, obstructive uropathy, urinary tract infections, bleeding and clotting disorders, and trauma bladder catheterization. Urate crystals are normally found in urine in newborn babies under dehydration. They can produce a red discoloration of nappy, which you should not confuse with the hematuria. If you palpate, like if you see the diapers, it will be like a brisk dust appearance will be there, which sometimes mistaken for the blood. So any children with dehydration and you are suspecting hematuria, you have to think about renal vein thrombosis. And extraglomerular hematuria, it can be because of upper urinary tract infection problems like pyelonephritis or interstitial nephritis or acute tubular necrosis, papillary necrosis or nephrocalcinosis, or anatomical problems like hydronephrosis or polycystic kidney disease, tumors like Wilms tumor or rhabdomyosarcoma or angiomyolipomas, or it can be because of trauma. From the lower urinary tract, it can be because of cystitis or urethritis or urolithiasis, trauma or coagulopathy or heavy exercise, bladder tumors, and sometimes it is because of the factious syndromes. And vascular causes like renal arterial or venous thrombosis or malformations like aneurysms or hemangioma, nutcracker syndrome, where the left renal vein will be compressed between the superior mesenteric artery and the aorta. which can cause like hematuria, or sometimes it is called proteinuria and postal proteinuria and all those things. Or hemoglobinopathies like sickle cell trait or disease which can cause papillary necrosis and cause hematuria. Or cystinuria because of calcium or oxalate or uric acid crystals, or medications like NSAIDs, anticoagulants, and cyclophosphamide, which can cause hemorrhagic cystitis. And in the history, you have to take what is the age of the child. If it is more 2 to 5 years, mostly it is because of Wilms tumor, and 5 to 12 years, it can be because of post-apical glomerulonephritis. And in females, it is more common in less than 1 year. It is because of urinary tract infections. In SLE nephritis, also most common in females, but X-linked Alport syndrome, which is more common in males. And whites normally can have more idiopathic hypercalciuria. Blacks can have more of like sickle cell disease, which is causing the hematuria. And in the history, you have to take about the you have to ask about the characteristics of urine, like amount of urine, whether it is reduced. It can be reduced in acute glomerulonephritis or acute renal failure. If you see clots in the urine, it is because of extraglomerular cause. If there is an increased frequency, dysuria, recent anuria, you have to think about urinary tract infections. If there is a frothy urine, suggest proteinuria, which can be seen in more in glomerular diseases. And timing. The initial stream, if you see the blood, it is mostly from the urethra, like urethrosia spotting in underwears, or terminal with the suprapubic pain, disturbance in micturition, it is mostly from the bladder. You have to see the associated symptoms like fever. It can be seen in infections, urinary tract infection, SLE, or acute glomerulonephritis, or facial puffiness, edema of legs, weight gain, shortness of breath, which you can see in acute glomerulonephritis, hypertension, like headache, visual field changes, epistaxis, seizures, abdominal pain, painless. It is mostly in case of glomerulonephritis. Abdominal mass, it can be seen in hydronephrosis or polycystic kidney disease or Wilms tumor. Joint pains, we have to suspect HSP or systemic lupus erythrocytosis. Rashes seen in HSP, SLE, and polyarticular nodosa. Jaundice, it will be seen in hemolysis or obstructive jaundice. History of exercise, menstruation, or recent bladder catheterization or passage of calculus. You have to ask these histories. Recent upper tract infection, if it is a 1 to 2 weeks back, or skin infection, mostly it can be because of post-apical glomerulonephritis. If you have respiratory infection within 1 to 2 days, if you have hematuria, mostly it can goes in favor of IgA nephropathy. So if after upper respiratory infection, if after 1 to 2 weeks, mostly it goes in favor of post-apical glomerulonephritis. After 1 to 2 days, you have to think about IgA nephropathy. GI infections like HUS, HSP nephritis, cross hematuria preceded by URA like Alport syndrome, IgA nephropathy. History of bleeding from other sites, bleeding disorders. History of ingestion of drugs like rifampicin, which can cause like red color urine, brufen, chloroquine, metronidazole, and IV contrast agents, and cyclophosphamide. History of vision or hearing defects, you have to think of Alport syndrome. Family history will be positive in case of hereditary glomerular diseases like Alport syndrome or thin glomerular basement membrane disease, IgA nephropathy, urolithiasis, hypercalciuria, and sickle cell disease. History of consanguinity or affected siblings is positive in autosomal recessive polycystic kidney disease or metabolic disorders. After your thorough history, you have to see the examination. In this one, you have to mainly check for the blood pressure and any signs of edema or pallor, raised JVP or perabdominal mass, like you can see kidney mass in hydronephrosis, or bladder is palpable in distal obstruction, or tenderness is seen in HSP. You have to look for any skin lesions like purpura or butterfly rash or bruises, or abnormal external genitalia like ambiguous genitalia in Vager syndrome, which is consists of Wilms tumor, aniridia, genital anomalies, and mental retardation, and Wilms tumor with hypospadiasis and cryptorchidism and genital trauma. Joint swelling tenderness will be seen in HSP and SLE, and ophthalmic examination is a must in Alport syndrome because there is a anterior lenticonus and macular flex will be there, and recurrent corneal erosion. Aniridia can be associated with Wilms tumor. Hearing assessment should be done in Alport syndrome where it is associated with bilateral sensory neural hearing loss. Normally, this hematuria can be present in these 4-5 presentations. Normally, it is incidentally discovered asymptomatic microscopic hematuria or microscopic hematuria with proteinuria, microscopic hematuria with symptoms, microscopic hematuria with intermittent gross hematuria or gross hematuria. So these are the red flag signs. Whenever you see hematuria, with proteinuria or hypertension or fluid overload, plank or abdominal mass, or if the patient is immunocompromised, you have to immediately evaluate thoroughly. So how to evaluate? So the basic investigation is urine dipstick test. It is based on the peroxidase-like activity of hemoglobin. It can detect traces amounts of hemoglobin and myoglobin. It can even detect 5 to 10 intact RBC per millimeter cube of unspun urine. It can be false positive when the urine pH is more than 9 or when there is a hydrogen peroxide is contaminated with the urine. It can be false negative when there is a high ascorbic acid or formalin in the urine. So also for you have to check for urine dipsticks for urine albumin. Dipsticks have a sensitivity of 100% and specificity of 99% in detecting 1 to 5 red blood cells per high power field. So other thing is next one is urine microscopy. Red blood cells per high power field. You have to centrifuge the urine and decant the supernatant and resuspend the sediment. Place a slide and you count the number of RBCs in 20 fields and report the average. If it is more than 5 red blood cells per high power field, it is called hematuria. In the same way, you have to do it in the cubic millimeter, where you will use the RBC count or same slide which you are using for RBC red blood cell count. If it's more than 5 RBC, it is called hematuria. The next thing, so how to interpret this one? So if the dipstick examination is positive, but there are no red blood cells on microscopy. Sorry, red blood cells are seen on the microscopy, it is hematuria. Dipstick examination is positive, but there are no red blood cells in the microscopy. It can be because of hemoglobinuria or myoglobinuria, which can cause dipstick positive. Dipstick examination is negative. It can be because of some dyes or pigments other than hemoglobin or myoglobin. So this is the approach. First, you have to centrifuge. See the sediment is red. It is hematuria. Supernatant is red. Dipstick examination is positive. Myoglobin or hemoglobin is present. If it is negative, it can be because of beetroot or fruits, phenopyridines or porphyria and other diseases. Plasma color is clear. Can be myoglobin. Plasma color is red. It can be hemoglobin. So these are the some conditions where you can have red or brown urine with negative dipsticks, like beetroots, blackberries, nitrofurantoin, rifampicin, urates. All these can cause pink or red urine. And dark brown or black urine can be seen in alkapnuria, homogenetic aciduria, methemoglobinemia, and thyrosinopsis. So how to different? So now you have down, and you have come to hematuria. The next one is to differentiate between glomerular and non-glomerular hematuria. So if there is a red cell cast, which is pathognomic of glomerular disease, or protein excretion greater than 100 milligrams per milliliter at any time when there is no gross bleeding, and RBC having a dysmorphic appearance. If these things are there, it is glomerular bleeding. The presence of more than 30% of dysmorphic RBC or more than 5% of a specific form named as acanthocytosis. Acanthocyte is highly suggestive of glomerular hematuria. So this is called red cell cast, and these are like you can say like this donut shaped one with these are called acanthocytes. So when acanthocytes and red blood cell cast is there, mostly it is because of glomerular hematuria. So what are the investigations we have to do? Renal and bladder sonography, urinary tract anomalies such as hydronephrosis, hydroureter, nephrocalcinosis, tumors, and urolithiasis. Renal peritoneal disease can be diagnosed with renal and bladder sonography. X-ray QUB will be helpful in calculi. Doppler study of the renal vessels and IVC is useful in renal vein thrombosis. Intravenous urography, spiral CT scans will be used in stones or Wilms tumor. Micturating cystourethrium will be helpful in urethral bladder abnormalities like cystitis or recurrent UTI to rule out vesico-ureteral reflex. And radionuclide studies are helpful in renal functions and perfusions. Angiogram, chest X-ray. Renal biopsy, normally it is, there are some relative indications for renal biopsy like significant proteinuria, 3 plus or more, or nephrotic range proteinuria is there with hematuria, or recurrent persistent hematuria like microscopic hematuria more than 2 years, abnormal renal functions, hematuria, proteinuria, and with diminished renal functions and low C3 levels persistent beyond 2 months of onset of acute glomerular nephritis, absence of evidence of streptococcal infection, serological abnormalities like abnormal ANR, double stranded DNA levels, a family history of end-stage renal disease or evidence of chronic renal disease in patient, you have to think of renal biopsy. and how to evaluate asymptomatic, isolated asymptomatic microscopic hematuria. Patient doesn't have anything, only microscopic hematuria is there. You have to repeat the urine analysis weekly for 2 times. You should tell them to avoid any exercise before the urine analysis. If the proteinuria is persisting on repeat analysis, you have to do, we will go to the next slides. If the hematuria is persistent, review the history and repeat examination like blood pressure. If urine analysis is negative in the next 2 samples, no follow-up is needed. If the hematuria is persisting in the next 2 samples, you have to review the history and repeat the blood examination, blood pressure. If the blood pressure is normal, then you have to obtain the urine culture. If the urine culture is positive, treat the infection and recheck the urine analysis after the infection clears. If it is negative, you have to follow every 3 months with history, examination, and urine analysis, including the RBC cast. If it is still negative, then if the proteinuria on analysis when you are following up in the next every 3 months, if the proteinuria is still present, you have to evaluate microscopic hematuria with proteinuria. We will go through those slides. And if the hematuria persisting, so without any symptoms, like your examination is normal, your blood pressure is normal, no signs of any rashes or anything, only hematuria is present consisting, then you have to evaluate the urine analysis every 1 year. Then you have to do the urine calcium by creatinine to see any renal stones disease is there, or test the parents' urine for familial hematuria, Doppler ultrasound to rule out nutcracker syndrome, hemoglobin electrophoresis to rule out sickle cell disease, and refer to pediatric nephrologist. And if the examination is positive for symptoms like hypertension, edema is there, you have to go for the next slide, which is showing symptomatic microscopic hematuria. So if there is isolated hematuria, these 3 outcomes will be there. The hematuria will disappear completely, or the new symptoms will emerge, or hematuria will persist without any new symptoms. So what are the causes of transient microscopic hematuria in children? After exercise, after fever, trauma to kidney or urinary tract infection and urethritis can cause transient microscopic hematuria in children. And this is the diagnostic algorithm for microscopic hematuria with proteinuria. So if there is asymptomatic microscopic hematuria with proteinuria is there, you have to measure the serum creatinine, and you have to do the quantitative urinary protein, 24 hours urinary protein, or the early morning voided sample for urine protein by creatinine ratio. If there is a elevated serum creatinine or the protein excretory rate is more than 4 milligrams protein per meter square per hour, then you have to refer to the pediatric nephrologist. Or if the protein concentration is less, then repeat the urine analysis 2 to 3 weeks later. If the hematuria still persists and proteinuria persists, refer to pediatric nephrologist. Only hematuria is there, but proteinuria disappeared. Follow up as asymptomatic isolated proteinuria, like every 1 year you have to do the follow-ups. And hematuria and proteinuria completely resolves. You can go to the routine pediatric care. So this is the algorithm for gross or symptomatic microscopic hematuria in children. If there is a gross or symptomatic microscopic hematuria is there, first you have to check whether there is history of trauma. If there is history of trauma, go for CT abdomen and pelvis to rule out any trauma, like any injury to the renal system. If there are no history of trauma, look for any signs and symptoms of urinary tract infection. If there is S, then treat the urinary tract infection and repeat the urine analysis. If there are any signs and symptoms of perineal or meatal irritation, it can be due to metal infection, then you have to resume supportive care. If there are any signs and symptoms of kidney or urethral stones, image in the kidney like USG or abdominal plain X-ray. If there are no history of trauma, no signs of symptoms of urinary tract infection, or no signs of perineal irritation, no signs of stones, then you have to think of look for any signs and symptoms of glomerular source, like proteinuria is there, red blood cell casts are there. If there red blood cell casts are there, it is gross hematuria, you have to refer to the pediatric nephrologist, and normally they will do the urea, creatinine, electrolytes, CBC, C3, C4 levels, albumin, ASO titers, and ANA antibodies. If there is no signs of glomerular source, no obvious cause of history and physical examination, urine examination, everything is normal, consider urine culture, urine calcium by creatinine ratio, test parents for hematuria, hemoglobin electrophoresis, and kidney USG. With these things, if diagnosis is apparent, then you treat the cause. If there is no, you have to refer to the pediatric nephrologist. So how to manage? there is no specific treatment for hematuria. We have to treat the cause. Reassurance and follow-up is needed in mostly asymptomatic microscopic hematuria. Treat the cystitis or pyelonephritis or rectal glomerulonephritis with antibiotics. Supportive treatment is required in diuretics or fluid and salt restriction, and antihypertensives can be used. Monitoring the blood pressure, input-output charts, weights, and urine routine microscopy, and treat hyperkalemia, or acute renal failure, or congestive heart failure, acidosis. And AC inhibitors are useful in treating the proteinuria. Immunosuppressive therapy depends on the cause, like steroids and cyclophosphamide can be used. And idiopathic hypercalciuria, you can use hydrochlorothiazide, potassium citrate, or sodium restriction. And calculi, you have to tell them to take plenty of water. If the patient goes into end-stage renal disease, you have to treat them with dialysis or renal transplantation. Catheter thrombocytopenia, anemia, and coagulation factors deficiency. And renal vein thrombosis, you have to use the anticoagulant therapy or thrombectomy may be needed. Surgical correction is needed in case of calculi or PUG obstruction or posterior urethral valve or Wilms tumor. So these are the some of the indications to refer to pediatric nephrology, like hypertension more than 95th percentile for age and height, oliguria or anuria or signs of any fluid overload, hyperkalemia, significant proteinuria more than 2+ and dystic, albumin creatinine ratio above the limits for the normal, atypical complement pattern like low C3 beyond the 12 months or low C4 identified, abnormal vasculitis screening, diagnosis of glomerulonephritis likely, persistent isolated microscopic hematuria more than 2 years, familial hematuria or macroscopic hematuria with no medical causes identified, you have to refer these patients to the nephrologist. And cystoscopy, it should be reserved for the rare child with a bladder mass noted on the ultrasound or for those with urethral abnormalities due to trauma. So in a nutshell, first, if there is a child with hematuria, first you take the proper history and examination, do the urine analysis, diagnose the hematuria is there or not, then check whether it is the glomerular, non-glomerular. If it is a glomerular hematuria, do the urea, creatinine, electrolytes, ASO titers, C3, spot urine protein by creatinine ratio, serum albumin, and cholesterol levels. If it is consistent with the post-temporal glomerulonephritis, give the supportive treatment and treat the hypertension azotemia. If there is not consistent with post-temporal glomerulonephritis, do ultrasound, ANA, anti-double stranded DNA, ANCA levels, family history, and hearing and visual examination, renal biopsy. If it is a non-glomerular hematuria, do the first thing is do the urine culture. If it is positive, treat the infection. If it is negative, do the urine ultrasound and voiding cystourethrogram. If it is abnormal, you have to think of hydronephrosis or PUJ junction obstruction or cystic kidney disease, tumors, or vesicular reflux, or lithiasis and renal vein thrombosis. If it is normal, you have to check the urine for calcium and creatinine ratio. Then if it is urine calcium by creatinine ratio abnormal, you have to do the hypercalcinuria, check for 24 hours urine. If it is normal, think of bleeding disorders, meningitis, or idiopathic causes. These are my references.